for inviting me. I've had a busy day. I began with a talk to the Gannett folks at noon, so it was action-packed to be able to see all of them earlier today and see all of you this evening. What I said to them, I'll also say to you. I think sometimes when I'm asked to give a talk, there's a lot of this like, really? You'll come? Really? That's going to happen? It's, for me, a tremendous pleasure to be here. It feels like it helps the work that I do to be talking in more settings and with more folks who are interested in this work and making sure that we've got facts that we all share in common, that good ideas for new studies come from all sorts of sources. So maybe we'll have a great idea for something new that we want to learn more about in the conversation we have together tonight. And it's always a great thing. So if you want more, ask for more. We'll do that too. So the talk, as it got circulated and advertised, has a slightly different title from this one. But I decided to make a little bit of a change. There was interest from when we first started talking about this event all those months ago, and interest in hearing some about DSM-V, hearing about the new diagnostic manual, the new labels for eating disorders, making sure we know what falls into what category with some of the new lexicon that's gotten identified and developed. And I'm happy to do that, but I thought it's hard to only do that. And so I made this into a little bit of a clinical update, just so that in a few areas where we have a couple of things that are new, we have a chance to throw that in together with the labels that are new, and the diagnoses, which have a little bit of new in them. Please feel free to ask questions along the way and drop me. I'm really fine with that. And hopefully we'll have time at the end for plenty of questions and answers. Okay, so I'm going to talk about diagnosis. I'm going to talk about DSM-V. I'm going to tell you a little bit about the process, because I was on a work group that spent a lot of years. I think all told, it was 6 years from beginning to end, thinking about the diagnostic system we had and thinking about what, if any, changes we wanted to make. But I'm going to say a little bit also about epidemiology and just a couple of things that we now know as some of our latest numbers, and you'll find that interesting. And then just a touch on treatment, with most of my focus being on, all of my focus, I think, being on anorexia nervosa, and just a couple of new things that are out there, so you hear about those. But as I say, at the end we can certainly answer any questions you might have. So, how many people have heard of the Diagnostic Statistical Manual of Disorders? Okay, we've got an informed group. So, DSM, gets a lot of press and a lot of attention, but really, the attention was associated with its first introduction in 1980, when DSM-3 really took the field of psychiatry from a place where the clinicians used lots of different terms and meant lots of different things, even when using the same terms, and started to get everybody using at least the same words for talking about clinical syndromes. And that was a tremendous step in the direction of the professional field having a language that allowed us to do research, allowed us to know that the patients who were going to participate in the given study all probably had the same symptoms. But over the years, the diagnostic manuals have become a little odd, because they seem to suggest that these are illnesses that fall so neatly into the categories. And of course, human beings don't really work like that. So now these manuals have come under a lot of criticism, where people are saying, what are you doing defining it that way for? And I don't know, I always thought of it this way. And clearly, we're going to need to understand a lot more about the brain and about the mechanisms that are responsible for the initiation and the sustaining properties of these illnesses before we're really going to know what falls in or out of any given category. But we do the best we can. And every so often, there have been new versions of this manual in an effort to keep current and bring all the data that we do have into the way we use the language. Before this DSM-V, which came out last May, it had been 19 years since the last volume. So it was time. And actually in eating disorders, believe it or not, there were fewer changes than what we see in some of the other areas of psychiatry. It's not the only manual out there, it's not the only language exactly that we have for talking about patients. There's an international classification system as well, ICD, and for the most part those things kind of work together, but not always. The ICD now is coming up with a new version, and they're really trying to figure out how much of what's in DSM-V they're going to keep and how much they may switch around. We can answer questions about that as well. Okay, so here's the list of feeding and eating disorders in DSM-V. Does it surprise anyone that the list is this long? There are some new categories that either hadn't been used at all in DSM-IV, or they were used, but they were hidden in other parts of the book, and many people had no idea what some of these labels really were about. So I'll tell you some about what's on this list, but specifically I'm going to focus on 4 categories. So anorexia nervosa and bulimia nervosa, of course, are the illnesses that you know the most about, and we made small but important wordsmith changes to those categories. But the other 2 are actually new to the list. Avoidant restrictive food intake disorder is a reworking of a hardly used category that was in DSM-IV in another chapter. And binge eating disorder, as I'll explain, there was a decision to take that formal disorder in the front of the book, no longer in the appendix where it just got mentioned as an aside. So it was interesting, this process of DSM-V. There was leadership, there was a task force that had to think about generally, how are we going to do this? How are we going to think about all of these categories and all of these illnesses? And what are we going to have the principles? How are we going to outline the principles to those who really work in these specialty areas? What if they want to turn the whole thing on its head? What if they want to make small changes, big changes? How are we going to guide them? And lots of meetings, lots of words, lots of handouts, but I could summarize the recommendations to us. I was on the work group for the eating disorder section. We were told to make changes in these 2 circumstances. So these are the changes that were going to be supported by the general task force. You can make changes that would clarify the diagnoses, and you could make changes that would decrease. Is this our first? What?
Special one too.
Special boy. That's my son. We can make changes that decrease the non-specific, not otherwise specified category of diagnoses that really had been this big, enormous problem in the prior volume of this thing, in DSM-IV. So DSM-IV, for every chapter, for every category, there was major depression, there was dysthymia, different kind of mood disorder, there were all sorts of mood disorders, and then you'd wind up with depressive disorder not otherwise specified, right? Schizophrenia, psychotic disorders, you wind up with psychotic disorder not otherwise specified. And certainly in the eating disorders, we only had anorexia nervosa and bulimia nervosa, and everything else fell into eating disorder not otherwise specified. It turned out that in eating disorder clinics, 60% of people who present didn't meet criteria for any of the formal categories. They landed as not otherwise specified, and it was a mess. And we didn't know who they were, we didn't know what they were really presenting with. Was it a little bit of this, was it a little bit of that? And they landed in this big, unspecified category, and the DSM group knew that this was a problem field-wide, and we were allowed to make changes that were going to decrease the number of individuals who landed in this hodgepodge. And so you'll see those as motivators when I talk about these diagnoses. So I'm really going to just run through the diagnoses that we now have in DSM-V. I'm going to tell you how we thought about it. Then we'll get to some of those other things that I said. So anorexia nervosa is where we'll start. And anorexia nervosa had 4 criteria for its diagnosis in DSM-IV. And we just went through criterion by criterion to try to figure out where was their trouble, did we want to make any changes, and And as I said before, these are actually the diagnoses where we sort of had quite minor alterations. So the first was you had to be low weight, right? You had to be low weight, and the wording in DSM-IV used this funny word refusal. You had refusal to maintain a normal body weight, and it gave this example. An example was less than 85%, there should be a less than sign, less than 85% of that expected. The stuff in red got everybody into trouble. Patients would present to their doc and say, moi, I'm not refusing. I'd love to be normal weight, I just can't, I don't feel well, I tried, and so in the most formal fashion, they didn't land formally into the category just because a funky word was used in that older version. Some pediatricians, some folks would say, I'm not really paying attention to the specific words, but certainly in the research community and some of the academic centers, they were getting stuck on some of these words. So we knew we had to make a change. And this other example, less than 85% of that expected. Nobody knew what was expected. And it was certainly only meant to be used as an example, and it wound up being used as a line in the sand. The insurance companies were saying, you're not getting reimbursed for your treatment if you're 86% of what's expected. It was really causing quite a mess, and so we had to make some kind of change. So we did, and just kind of took judgment out of it, restriction of energy intake relative to requirements, leading to a significantly low body weight, and we didn't tell them what that meant. So there's lots of text, the book's got lots more information about all the different ways that we can define low weight, but we didn't put it into a criterion. We learned that lesson last time. You needed to have an intense fear of gaining weight or becoming fat, even though underweight, and that, the same thing, fear. And someone would say, I'm not afraid, just tell me how it's done. I'm not afraid at all, and we wound up getting stuck. So the wording got changed to allow for the possibility of behaviors meeting this criterion, right? So it could be a fear. You could come in and say, I am petrified. I don't want this to happen to me. Or family or friends or clinicians or, right, could say, listen, she may say she's not afraid. He may say he's not afraid, but we see what's happening. We've outlined what needs to be done. There are all sorts of behaviors that get in the way of weight gain. And that should count as being reluctant to get where you need to go. Here we didn't make much of a change at all. There's a disturbance in body shape and weight concern and a denial of the seriousness of the current low body weight. We just changed the word denial to lack of recognition, but pretty much kept this criterion the same. And in the fourth particular, we had the requirement in DSM-IV that in postmenarchal females, there couldn't be any menstrual activity, right? And that was a big problem. That was a big problem. Anyone know why it's a big problem? Why was it a big problem?
Not for everybody.
It wasn't true for everybody. And there's really, over those 19 years since DSM-IV, a lot of data about individuals who met all the criteria for this illness who had or who didn't have menstrual activity, and there really wasn't a lot of difference in terms of severity, in terms of course, in terms of outcome. So it was a likely side effect of severe nutritional depletion, but didn't happen to everyone, and there didn't seem to be a difference among those that didn't happen to. We had other problems with it. Made it really hard to diagnose anorexia nervosa in a really young patient who might not have had a first period, might have been very seriously affected, but right, families, kids themselves, doctors even were having a hard time. Well, I don't know, do they meet criteria for this illness? They never had an interruption, right? It was hard for all the females who took cycling hormones. Anybody on oral contraceptive pills going to bleed? And they'd say, looks like everything's in good working order, but that's not a period, and it made it really hard to make this diagnosis. And males. We had an impossible time, and you've got significant numbers, somewhere between 1 out of 10 to 3 out of 10, different samples, are male with anorexia nervosa. What good is it if we make menstrual activity part of the diagnostic requirement? So that's gone. Okay, so for DSM-V, we now have 3 criteria near the items I just mentioned. We still have 2 subtypes, the restricted or the binge purge subtype, and I'm happy to answer any questions if there are any. And pretty much we explained to that leading task force we were doing these changes out of trying to clarify, and getting rid of that amenorrhea criterion was going to decrease the number of folks who landed in that unspecified NOS category. So we were following instructions, and we made these changes. For bulimia nervosa, it was a little bit more straightforward. Pretty much we kept all of the criteria exactly the same to those that had been there previously. We just changed in that criterion C that the frequency of these symptoms, right? You've got a binge eat, which means eating an amount of food that's clearly more than what's appropriate for a given situation, and eating in a fashion that comes with a loss of control and a real feeling of distress. Those episodes are accompanied by something that you do to compensate for having just eaten in that way. Usually that's vomiting behavior, but it might be some other form of purging. And those episodes need to happen at least once a week. In the old volume, they were needing to happen twice a week in order to meet criteria. A lot of evidence over the last 19 years that there's no difference in severity, in course, in outcome among those who are once a week versus twice a week. So we thought we could bring them in. We get to patients earlier, right? When patients first begin with these symptoms, they may not have the symptoms quite as frequently, and if we could intervene, if we could get them some treatment, if we could identify this for what it is, we'd be doing better for them. And we didn't really think we were bringing in a whole new population that would have otherwise gotten to us eventually. So EDNOS and this NOS category would certainly decrease by making that change. And we got rid of an old subtype classification because nobody ever used it. Purging versus non-purging. Nobody was using that. All right, so among the bigger changes was bringing binge eating disorder to the front of the book. So binge eating disorder was identified. People had heard of it. This is a problem where people have those episodes of eating in that very out of control, very distressing way without any of the compensatory behaviors. When DSM-IV came out, the thought was, we need more study for this. We really need to think about this a little bit more. We're not going to call it a formal diagnosis yet. And in the 19 years since that volume, there were well over 1,000 publications taking a look at this population. So we had a lot of information that we could go over. And pretty much we kept the diagnosis the same as what it was with just a small tweak. But among the things we did in a very careful review and a published review of how we were thinking about this disorder, because there was a lot of lay literature saying, you're now going to take every person who eats a pint of ice cream when they didn't feel like it, or they didn't think it was good for them, and you're giving them a psychiatric diagnosis, and what the heck are all of you guys doing? And we really wanted to carefully approach the instructions of how we were going to think about these diagnoses. So we wanted evidence of real validity and clinical utility, clinical usefulness for this diagnosis. We had lots of laboratory testing data that said that binge eating behavior is clearly different from people who were equal weights who didn't endorse binge eating. So if you put people in the lab, what people with binge eating disorder do there is different. And we were able to measure that, and then many other investigators have measured it as well. So we thought we had something. We had some data to support this. Certainly, individuals with binge eating disorder have higher rates of mood and anxiety symptoms than do equally overweight or obese individuals who don't have binge eating disorder. So again, it's something that the clinicians had to worry more about. We had suggestions that folks with binge eating disorder do not respond to the same treatments as overweight folks who don't have these symptoms. So even in weight clinics, even where treatments should be helpful, we had this other group who were not responding equally. So again, a reason to sort of identify for clinicians that this is really a problem. We also had to do a lot of work taking a look at prevalence. What was going to happen if we really made this identifiable disorder with the tweaks and the little word changes we were contemplating? Were we now going to have, half the American population diagnosed with psychiatric illness? And the numbers were really important, and this study happened to be a very well done study that took a look using the DSM-IV criteria and the planned DSM-V criteria for binge eating disorder, looked at very large community samples to see how many people come out positive for this disorder. It's 1.6% in the old lexicon, 1.7% of females, and 0.8% of males, and that's it. We're describing something that describes a small but important part of the population. And that also was useful as we were trying to justify that this is a problem, this is a disorder, and it's not going to turn the whole nation over to becoming a psychiatric population. So the only change we made was to that frequency. We wanted to line it up with bulimia nervosa frequency, and so once a week for 3 months was identified for this illness as well. And here too, this was thought to really decrease the numbers of folks who landed in that unspecified group. That other category listed at the very beginning of the talk that made some of you squint, that avoidant restrictive food intake disorder thing, which already has an acronym, ARFID, believe it or not. It actually came out of another disorder that was in the old DSM. It was in the old DSM in the pediatric section. None of us in eating disorders ever paid it any mind. It's called feeding disorder of infancy or early childhood. But essentially what it described are young people who aren't eating normally, aren't eating enough, but they don't have anorexia nervosa. They're not eating in some very peculiar, particular ways, consistent ways, ways that get them into trouble, but it's not because they think they're fat, it's not because they've got body image worry, it has to do with something else. And we decided to really define this more carefully, test it out with a lot of child psychiatrists, pediatric groups, adolescent medicine groups, and see whether the kinds of things that we were trying to understand better from this old category and what we were hearing from our colleagues really needed some good identification, whether we could do a better job of describing it in this DSM-V. So this is an eating or feeding disturbance that really has lack of interest in food or avoiding food because of the ways things smell or feel or something that's about the sensory characteristics of food. Worries about the aversive consequences of eating. People who are afraid they're going to vomit. People who are afraid they're going to choke. Right? There are a whole collection of folks who don't eat, but they need to eat. They get into tremendous nutritional trouble. And it has nothing to do with the anorexia nervosa. They may have significant weight loss. They may have significant nutritional or vitamin deficiency. They may become dependent on ensures or liquid supplements or NG tube feedings. And they may have very significant impairment in psychosocial functioning. That's its own category, and we're calling it ARFID. Okay? Can't be due to another medical condition. It can't be due to anorexia nervosa. And the reason that we really amped up the language here was because we wanted to decrease that EDNOS category. So we actually asked our friends in adolescent medicine to take a look at these old and new categories of eating disorders. For a young population, they had 215 young people who presented with some kind of eating problem. And using the old DSM-IV definitions, you saw a group with anorexia nervosa, a group with bulimia nervosa, not too many by the way, and most people landed in this EDNOS category. When we moved to using the new terminology with all of those diagnoses I just showed you, you had a slightly higher number who landed with anorexia nervosa, because we no longer needed them to have an interruption of their periods to meet criteria. You had a very small but an increase in bulimia nervosa, because now you might catch those who are having those symptoms once a week instead of just those who progressed to twice a week. And you have a big decrease in how many land with this unspecified category, and much of that is really accounted for by the fact that the adolescent medicine docs had no problem finding individuals who seemed to meet for this ARFID category. They published on this, they described these numbers, they actually asked, well, like, does ARFID happen to all the same kids that we otherwise were treating for anorexia or bulimia? Is this something different? And sure enough, there's some differences. Individuals who met criteria for ARFID actually were younger when they presented, when their families brought them into the pediatrician, than what you saw for anorexia nervosa. Their weight was low, but it wasn't as low as what you saw for anorexia nervosa. And they had been affected by whatever these symptoms were for a really long time, right? On average, years, right? 33 months, as opposed to families who were dragging their kid with anorexia or bulimia. A little bit better gender balance than what we saw for anorexia or bulimia. female, 71%. So we really thought that we were onto something, and this has made it to that front of the book. So enough with DSM, and I'll just mention a few other things that are new and that have come out more recently in the literature, just to give people a couple of other pearls. Epidemiology, who has what numbers do we know? We've got better follow-up data than we used to. We've got larger samples, so we can really better describe who gets these illnesses and what happens to them. We also have more data available from outside of North America and Europe, and that's always been a question with these illnesses, and I'll say more about where we're at in that regard. So in large prevalence studies, here's what the numbers look like. It's not an epidemic, but the numbers are significant. So you see that less than 1% of women in their lifetime will be affected by anorexia nervosa. About half again as many affected with bulimia nervosa in their lifetime, and you see larger numbers affected in their lifetime binge eating disorder. You saw lower numbers of prevalence before for binge eating disorder, and that's because those were point prevalence. At any point in time, how many people are affected. This is looking at, in the course of a lifetime, how many people might ever have been affected. You can see the lower numbers for men, in this particular sample, men were affected with anorexia nervosa 1 out of 3. That's a relatively high percentage. In other samples, we see lower, and you can see where the numbers are. You've got the most gender equity in eating disorder. That's from a national comorbidity study. We also know a little bit about when people enter into that lifetime prevalence, when they develop the illness, so when they then join the group of people who've ever in their lifetime been affected. So for anorexia nervosa, pretty much the tail is done by somewhere in your early to mid-20s. Right? So if someone is going to be affected by anorexia nervosa, it usually happens in adolescence or in one's young adult years. And if it doesn't happen by then, it doesn't usually happen. There's been some, lay press about, is there a middle-age anorexia nervosa? Almost always, if you really get a full story, you understand that there were some eating disorder symptoms that might have been present at some point previously, and you might see a resurgence, you might see a worsening, you might see something that happens, but it's very unusual, not impossible, but very, very unusual for people to have anorexia nervosa for the first time at age 45. So, develop the illness, and then this is the prevalence rate going forward. For bulimia nervosa, you see that the illness may continue to capture new cases into adulthood, but there too, there becomes a point where people don't all of a sudden at age 60 start to develop new bulimia nervosa. For binge eating disorder, you're seeing, right, people enter into that illness group all the way through lifetime trajectory. We also talk a little bit about when people first present with an eating disorder and how that has changed over the ages. People are developing anorexia nervosa younger now than they used to some decades ago. I don't know that the total numbers of people affected are any different, but they're first presenting at a younger age. So this study is interesting because there's an age cohort based on when people were born, right? So people who were born 1972 to 1985, you can say this is still a very old study, but still, 50s to 70s, 40s through 50s, and before 1944. In the older cohorts, right, you see people first developing anorexia nervosa at 20, and in the younger cohorts, you see that they're developing anorexia nervosa in young to middle adolescence. That's a relatively new phenomenon in the 20th century. We also know more about rate of death associated with eating disorders. And if there's one take-home from this talk, it's that these are very dangerous disorders. So anorexia nervosa is associated with the highest rate of death of that seen in any psychiatric illness. And that's often a particularly dangerous reality because lab values may not be abnormal when somebody presents with this illness. An individual affected may really deny that much is going on or that there's anything to worry about. and yet the rates of death are very high. So we've got weighted mortality, which is deaths per 1,000 person years, but you also have a standardized mortality ratio that's saying how much more likely is somebody with anorexia nervosa to die compared with an age-matched, right, group that doesn't